Welcome today to our webinar. I'm Melissa McFeeters. I'm a senior scientist at RTI International, and we are the Recover Administrative Coordinating Center. One of the things that we get to do as the ACC is to put on these webinars, and so we're so excited to do another one today. So welcome to the Recover Research Review, or R3 seminar. The goal of our webinar series is really to catalyze a shared understanding of the research of the scientific stakeholder community within the Recover Consortium. It's important that we note that this seminar series is focused on scientific research. It's not intended to provide any clinical guidance. I want to start by thanking all of you who registered and submitted questions in advance. If you have questions during the seminar, please submit them, as Shane said, using the Q&A feature in Zoom. We'll be keeping an eye on those, and after the presentation, we'll answer as many as we can about today's topic. Some of the questions may also appear in Q&As that we'll be posting on our website. We very much want to get to everyone's questions, but we do get a lot of questions during the webinars. We will be collecting them, and we'll be working hard when we go to post the video of this webinar on our website. The Q&A will be right there with it. There are also lots of other materials on the website, which is recovercovid.org. So you should feel free to go there to see if there may be additional answers for some of your questions on our FAQs that we continue to add to. There are also questions about other scientific topics there and about future webinars. As I said, this is part of a series, and there are lots of other interesting topics coming up. We hope you'll join us for more of these. Today's speakers will be providing an overview of dysautonomia and diagnostic approaches, and then describe what is known about dysautonomia and PASC, as well as what the research is showing us about treatment strategies. I think it's a very important and timely topic, and we're so lucky to have such great speakers with us today. So let me tell you a little bit about them. Dr. Mitchell Miglis is a fellowship-trained autonomic and sleep disorder specialist at Stanford University. He treats a wide variety of neurological diseases and has a special interest in autonomic disorders, sleep disorders, and the interaction between these conditions. His current research interests include mechanisms and treatment of postural tachycardia syndrome and long COVID and PASC. Professor Lauren Stiles is an attorney and a research assistant professor of neurology at the Stony Brook University Renaissance School of Medicine. She's also president of the Dysautonomia International, which she founded in 2012 after her own experience with the condition. She's going to share some really interesting information today about symptoms, and really looking forward to that. Dr. Peter Novak is the director of the Autonomic Laboratory at Brigham and Women's Hospital. He's a board-certified neurologist and a board-certified autonomic specialist. He has special interest in autoimmune small fiber and autonomic neuropathies associated with MCAS, hereditary alpha tryptophanemia, COVID-19 and Lyme disease, postural tachycardia syndrome, PASC, and multiple system atrophy. Lots there. He's going to talk to us about findings in recent studies of dysautonomia and PASC in particular. Dr. Taewon Chung is an assistant professor of physical medicine and rehabilitation and neurology at Johns Hopkins. His main areas of clinical interest are myositis and POTS dysautonomia. He founded the Johns Hopkins POTS Clinic, which is a multidisciplinary program with physiatrists, nurse practitioners, and physical therapists. He also established Johns Hopkins Autonomic Laboratory. He'll be talking to us today a little more about what we're learning about treatment in the research today. And finally, we're lucky to have a great discussant with us today who's going to help tie this all together. Dr. Satish Raj is the section chief of the Adult Cardiac Arrhythmia Group at the University of Calgary in Alberta. His primary research interests relate to understanding and better treating postural tachycardia syndrome, vasovagal syncope, orthostatic hypotension, and initial orthostatic hypotension, and now long COVID. So without further ado, I'd like to hand this over to our fantastic speakers. So Shane, if you could tee up our first person, Dr. Miglis, that would be terrific.
Great. Well, thank you to the NIH for allowing us to present on this very important topic. Next slide, please. So I'm going to start with an overview of what dysautonomia is and just the autonomic nervous system in general, and try to do this in 10 minutes. So the autonomic system is an incredibly complex component of the nervous system that maintains homeostasis or equilibrium in the body. And we generally divide the autonomic system into three components. The sympathetic, which is regulates fight or flight responses. And it generally does this through the release of epinephrine and norepinephrine. and the parasympathetic system, which regulates rest and relaxation, and generally accomplishes this through the release of acetylcholine. As we can see here, the autonomic system innervates almost every organ in the body. And when we're evaluating patients with autonomic disorders, we try to localize sort of which organs are involved, common organs that we see involved in our patients, and this applies to those with PASC, include the heart, blood vessels, gastrointestinal system, genitourinary functions, sweating, and pupillary functions. And then as neurologists, we sometimes like to localize where the disorder is. Is it coming from the brain or the spinal cord or central, or is it more in the peripheral nervous system, the peripheral nerves? We don't have all the evidence yet, but it does seem that COVID likes to involve the peripheral system preferentially. Next slide, please. So what is dysautonomia? So this is a term that we're hearing a lot these days. So it's an umbrella term that encompasses not only autonomic disorders, but autonomic symptoms. So it's not a specific diagnosis. It's sort of a catch-all descriptive term. Some conditions that are more specific that we do diagnose include postural tachycardia syndrome, or otherwise called postural orthostatic tachycardia syndrome, or POTS, orthostatic hypotension, recurrent neurally mediated syncope, autonomic neuropathies. Very common causes include diabetes, and very rarely familial dysautonomia. Next slide. So common disorders that we see and treat in our clinics are what we call disorders of orthostatic intolerance, and we'll define this term in the next slide. And these include orthostatic hypotension, or OH, POTS, and syncope. So one key distinguishing feature here that I want to draw everyone's attention to, is the difference between OH and POTS. So OH is a sustained drop in blood pressure of at least 20 points systolic or 10 points diastolic within 3 minutes of being upright. Patients may or may not have symptoms associated with this. POTS is defined as a sustained increase in heart rate of at least 30 beats per minute within 10 minutes of being upright in the absence of OH. So we cannot diagnose POTS if there is an abnormal drop in blood pressure. If that's the case, then the heart rate increase is most likely compensatory. Most patients with POTS have a heart rate increase of greater than 120 beats per minute. In individuals that are in the age of 12 to 19 and teenagers, the heart rate increase has to reach at least 40 beats per minute, and there has to be associated symptoms of orthostatic intolerance. There's a chronic duration here defined in the consensus statement of at least 6 months. This is evolving, but the point is POTS is thought to be chronic. Neurally mediated syncope is not necessarily a disorder by itself. It's a reflex that can happen to normal stimuli under stress. But if it is recurrent, which it can be in COVID, then we tend to define this as a disorder. Next slide. So orthostatic intolerance, this is a descriptive term that includes a lot of different symptoms, including the common symptoms of lightheadedness and dizziness, but also more non-specific symptoms like fatigue, nausea, shortness of breath. We query all our patients about this symptom, and when we're evaluating patients with autonomic disorders, we're trying to really get at, are these symptoms brought out, or are they worse with standing? Are they relieved with recumbency? Because most autonomic disorders are. Next slide. And Lauren's going to describe the symptoms in more detail, but I thought I'd include this. There's a reference here on the bottom of a review that we described a lot of these symptoms in, but this is when we were calling long COVID post-acute COVID syndrome. But some of the symptoms that we see commonly in patients with long COVID or PASC are orthostatic intolerance, tachycardia, temperature regulation issues, sometimes labile blood pressures or new onset hypertension, and a lot of GI symptoms. A lot of these symptoms are commonly seen in autonomic disorders. Next slide. So how do we evaluate these patients in the autonomic lab? How do we perform testing? And this is not readily available. This is only available in few select academic centers, but I thought I'd just give an overview of what we can do to help localize these symptoms objectively. So again, we're dividing the evaluation into sympathetic functions and parasympathetic. It's important to note that the testing we do really evaluates cardiovascular reflexes. We don't do gastrointestinal testing. We rely on our GI colleagues for that. rely on our urology colleagues for urologic testing. So aside from sweating, which is a sympathetic function, most all these other tests are evaluating cardiovascular reflexes. Next slide. And so this is what we'll see on a tilt table test in a patient with POTS. This is actually from our case report of the first patient that was published with post-COVID POTS. And what we can see here is blood pressure on the top. We measure blood pressure with a continuous beat-to-beat monitor here on the finger, so we can detect any sudden changes. We also like to correlate that with a manual blood pressure on the arm. And you can see here in the middle, the heart rate increases dramatically by 60 beats per minute. There's no drop in blood pressure. In fact, the blood pressure goes up, which we commonly see in these disorders of sympathetic hyperactivity. And so the patient has symptoms. With this tilt response, we're able to diagnose POTS. Next slide. In contrast, this is what we'd see in orthostatic hypotension. I'm not showing you the heart rate here, but the blood pressure drops on tilt up pretty significantly. The patient's symptomatic. The patient sits down, blood pressure increases again. If there was a dramatic increase in heart rate, we would not be able to diagnose POTS here because of this abnormal drop in blood pressure. Next slide. And this is what we see in a patient with neurally mediated syncope. We see a fairly stable blood pressure for several minutes during the tilt, and then a very precipitous drop in blood pressure and heart rate, resulting in loss of consciousness. Next slide. But we don't need autonomic testing to diagnose some of these disorders, including POTS or orthostatic hypotension. This can be done in the office. This can even be done at home by the patient. We give a lot of our patients home orthostatic logs to track this at home. And we're advocating that this should be included in evaluation of patients with PASC and suspected autonomic dysfunction. We should be doing orthostatic blood pressure and heart rate checks with at least a 5-minute rest period supine. And then we'll have the patient stand for at least 5 minutes and check the blood pressure and heart rate every minute. We like to do an active stand test and not a Vaseline test because it does produce more of physiological stress. Next slide. And then just to finish up very briefly, showing you some of the other tests we do in the lab. The valsalva maneuver measures very similar functions that the tilt measures. It's measuring the barrel reflex. And what we like to see is that we have a blood pressure, nice blood pressure increase when the patient is blowing into the tube on this we call phase 2. A patient with autonomic failure will not increase their blood pressure in that phase 2 with this stress. And what we'll see in POTS is actually the opposite. We'll see very dramatic increases in blood pressure, which also suggests a sympathetic hyperactivation. Next slide. And then the very simple test we do of parasympathetic cardiovagal function is just deep breathing. And we'll measure the change in heart rate with deep breathing. On inspiration, we should see an increase in heart rate, and on expiration, a decrease in heart rate. And so we simply calculate the difference on this heart rate change with deep breathing. If we see something where there's for instance, an autonomic neuropathy, where there's diffuse damage to the autonomic system, we'll see a significant reduction in this heart rate variability. Next slide. And then very final slide here. These are more specialized tests of sweating that we can do. A common test is called a QSART, where we'll infuse acetylcholine into this capsule, this vacuum sealed capsule on the extremities. And that will stimulate sweating, which is again a sympathetic function. And we'll see this nice sweat response here if the patient has normal sweat function. So this function is regulated by the small fiber, the small autonomic unmyelinated fibers in the skin. We're seeing a potentially significant prevalence of small fiber neuropathy with COVID. And in this case, the sweat function would be reduced. We can look at this even more specifically with a skin biopsy, which is a relatively non-invasive punch biopsy, where we can take a few millimeters of the skin and then stain this with axonal, panaxonal markers and just count the epidermal nerve fibers. This is a little bit more of a specific test and more readily available for diagnosis of small fiber function. And with that, I'll hand it over to Lauren to discuss common symptoms in PASC.
So I'm going to talk a little bit about symptoms, but also why it's so important that we understand autonomic dysfunction that's happening in long COVID as we study it, and also as we offer clinical care to these patients. So a little background, the idea that a virus or any infectious agent can cause dysautonomia is not new. The prior coronaviruses have also caused a post-viral syndrome in about half of patients, with a lot of symptoms that were similar to that's suggestive of autonomic dysfunction, and lots of other infectious agents can cause this. Is definitely not a complete list. Also wanted to highlight that it's not just POTS. Post-viral autonomic dysfunction can present in lots of different ways, causing different autonomic disorders, but it seems that POTS is probably the most common presentation that's appearing in COVID, although we do need further research to really clarify that. And I think Dr. Novak is going to share some of that with us later. I just want to talk about a little bit, 2 slides on like what is POTS, because I think a lot of clinicians are not really familiar with it. We don't have a lot of great training on autonomic disorders when people go through medical school, even if they're in electrophysiology or neurology fellowships. So POTS is defined by excessive orthostatic tachycardia on tilt, and its primary symptom manifestation is orthostatic intolerance. But really, the entire autonomic nervous system can be impaired in these patients, and they can have a wide range of symptoms. It's not just tachycardia. It is the most common diagnosis seen in autonomic clinics before COVID. Again, these numbers are before COVID. We had an estimate of 1 to 3 million Americans having POTS. I think that number, I would not be surprised if it has doubled as a result of COVID or even more, but we're going to need good epidemiology data to let us know that. POTS is about 90% female before COVID, peak age of onset at age 14, but I don't want anyone to think it's a pediatric only condition, because half of patients develop it in adulthood. I actually developed POTS triggered by a snowboarding concussion and probably worsened by having an autoimmune disease, Sjogren's syndrome, 10 years ago. I was 31 years old. So 50% of POTS patients have a post-viral onset. But we have other triggers like bacterial infections, concussions, pregnancy, car accidents, surgeries. And the thing that all of these have in common is that there's something that could stimulate your immune system and irritate your autonomic nervous system. And many people will bounce back from these problems without a problem, but there's just a subset of people who kind of evolve into this chronic autonomic disorder. And I'm hoping that RECOVER research is going to help us understand what that process is, what those risk factors are, and how we can help people kind of get their autonomic nervous system back to functioning more normally. So here's a symptom survey that I did with Dr. Raj, who is our moderator today. We surveyed, this is about 4,000 POTS patients. This is pre-COVID. And these patients, if you looked at the symptom list and the percentages of patients that reported the symptoms, it looks very similar to long COVID studies that are reporting on all the different symptoms in long COVID patients. So there's really a lot of overlap, and a lot of the symptoms we're seeing in long COVID, could potentially be driven by autonomic nervous system problems. So POTS patients universally have lightheadedness, and tachycardia is sort of part of the diagnostic criteria. I think that another really important thing to focus on is that 94% of POTS patients report headaches, 40% have migraine. Difficulty concentrating and memory problems are pretty much universal in POTS patients. And we actually have other studies showing it's not just in the upright position that this happens, that POTS patients actually have cognitive deficits in the supine and upright position. It's worse when they're standing up, but it's also present when they're laying down. They also have signs and symptoms of small fiber neuropathy, like numbness, tingling, and burning. And we have clinical research studies from multiple centers showing that about half or a little bit more than half of POTS patients have autonomic and sensory small fiber neuropathies. They have profound fatigue and exercise intolerance. This woman who has lent me a photo of her legs, we call this kind of for fun, purple POTS legs, but the more scientific name for it is dependent acrocyanosis. And it happens just after a minute or two of standing in about half of POTS patients. They also have a delayed capillary refill if you sort of press on their shin or their foot. And so this is sort of, a complex process. It's oversimplifying it to call it just blood pooling, but conceptually there's a problem with their hemodynamics. POTS comes with quality of life similar to end-stage renal failure. That's a study out of Vanderbilt that Dr. Raj was part of. Disability similar to COPD and congestive heart failure. That's a study out of Mayo Clinic. And it's weird, these are younger people that have sort of quality of life and disability. That's just usually what you think of in sort of older people who look a lot sicker. So I think one of the challenges POTS patients have is that they are generally younger looking people, and people assume that there can't be anything wrong with you. You look fine is sort of a common thing that these patients hear. So please, don't say that to your patients. Take their symptoms seriously. Also important to note, while they do have signs of sympathetic activation like tachycardia and tremulousness and whatnot, they have psych profiles similar to the national norm from a couple of different studies. So don't misinterpret their autonomic symptoms as, oh, that must just be anxiety. So quickly, the study that Mitch and I did is a similar survey looking at autonomic symptoms in long COVID patients. And we found that 67% of long COVID patients have moderate to severe dysautonomia, which we assessed using a patient self-report form, Compass 31. And importantly, the autonomic severity and the presence of autonomic dysfunction didn't differ between the hospitalized and non-hospitalized patients. So acute viral severity is not really predicting the autonomic problem. So the most common symptoms were very similar to the symptoms you see listed in the prior slides on POTS: fatigue, cognitive impairment, headache, shortness of breath, body aches, palpitations, lightheadedness, and tachycardia. And other PASC surveys have found this too. I'm not going to get into this in detail, but if anyone wants, you can get a copy of Compass 31 and the scoring algorithm from this open access article in Mayo Clinic Proceedings. And it's a good review of systems if you're working with PASC patients to try to understand if they have an autonomic problem, even if you don't have a full autonomic lab at your disposal. So we have good research showing that autonomic dysfunction drives a lot of these post-viral syndrome symptoms. Something we don't really talk about is the role of the autonomic nervous system in driving immune dysregulation and our coagulation pathways. So I have 2 slides on this. Just want to sort of plant the seed and get the idea out there in the research world as new research is happening. So if you haven't heard of the cholinergic anti-inflammatory reflex, I urge you to look it up on PubMed. There's a lot of really fascinating research happening in this space, and almost any discipline, no matter what field you come from, there's some relevance to your field in learning about this. This is basically how the autonomic nervous system, primarily through the vagus nerve, regulates inflammation and predisposition towards autoimmunity in the body. So once you understand the cholinergic anti-inflammatory reflex is this neural reflex that regulates inflammation, it kind of makes sense that people with autonomic dysregulation might end up with immune dysregulation. And so there's this great new research happening showing vagus nerve stimulation can provide some benefit in a wide range of autoimmune conditions, things like IBS. We have 4 studies in POTS so far with good preliminary data. And there are some trials happening in long COVID, and we're hearing some anecdotes and, kind of small case reports on this. So I think this is a space to pay attention to. It's actually very accessible and affordable if it can actually be done with a modified TENS unit. So I think it's something to look into if you're working with long COVID patients. And then last slide on a substantive thing I have is, so there's a lot of talk in the long COVID community about hypercoagulation and microclots, not only in acute COVID, but also in long COVID. And I don't have, that's not my area of expertise, but I do know that the sympathetic nervous system, which we are finding is sort of overactivated in a lot of long COVID patients. Sympathetic activation, even in healthy people, increases hypercoagulation. So, it increases coagulation, and that's part of normal physiology. I have this silly little cartoon, I'm sure everyone remembers, if you're being chased by a lion and you get scratched, you don't want to bleed out. So it's probably a good time for your coagulation to kick in. And unfortunately, when you have a virus, you're not being chased by a lion, but your body sort of is in that fight or flight state for a prolonged amount of time in a lot of the long COVID patients. Related to this, we have one study showing kids with POTS before COVID. Kids with POTS have an 11-fold increase of DVTs compared to other children using chest ports within the whole Children's National Health System. So I think that's a hint that this is going on in other people with chronic activation syndromes, not just necessarily in long COVID. So I hope that future research in Recover and other long COVID studies will really dig into the coagulation pathology and how this may or may not relate to the autonomic function. So my last slide, I just have some links that might be helpful to clinicians as well as patients. Dysautonomia International is offering, we don't have the NIH's money, but we're offering some research funding through the Long COVID Research Fund. And we also have an autonomic disorders video library with over 100 lectures from the top experts on autonomic disorders. So thank you very much.
Thank you. My name is Peter Novak. In the next few minutes, I will talk about post-acute cervical of COVID in the context of cardiovascular and autonomic abnormalities. So initial study did show that PASC affects about 50% of survivors of COVID infection. More recent studies did show 30%. Clearly, prospective studies are needed to clarify the true prevalence of the PASC. Neurological symptoms vary across patients and can be disabling, irrespective of severity of initial infection. Typical neurological symptoms are fatigue, brain fog, headache, sleep difficulties, cognitive and emotional problems, dizziness, muscle weakness, myalgias, hyposmia, sensorimotor deficit, and of course, dysautonomia. Neurological symptoms can reflect involvement of neural systems or can be linked to underlying organ dysfunction due to COVID. For example, affecting respiratory, renal, psychiatric, endocrine, hematologic, autoimmune systems. According to WHO and NIH, neurological symptoms are core aspects of long COVID. As of yesterday, there were almost 81 million of COVID cases in US, assuming 30% of COVID prevalence, which is kind of a conservative estimate. The total number of PASC is about 24 million. As to be expected, the highest prevalence in California and Texas. And in Massachusetts, we have about 500,000. The true incidence of PASC is still unclear. This is nice retrospective study from England, looking on the 273,000 COVID survivors. And they show incidence of 50% when combining any signs at 6 months. The most common was anxiety and depression, followed by abnormal breathing. Autonomic symptoms are very common. One survey did show that the most common symptoms were attributed actually to autonomic dysfunction. The Long Hauler Advocacy Project noted that 34% of patients with PASC patients had new diagnosis of autonomic dysfunction. And this is a low-end study that showed that in 2,300 PASC patients, 67% of PASC patients had dysautonomia, which was moderate to severe based on the COMPASS, which is a survey for autonomic dysfunction. Exact incidence of dysautonomia and its clinical significance is still not clear because of lack of objective autonomic testing studies. So these surveys prompted us to design a study to evaluate dysautonomia and related problems in PASC using objective tests. We used a comprehensive evaluation that I will explain in the next few minutes. So this was a retrospective study that included 9 PASC patients that completed comprehensive autonomic testing with skin biopsies. All had mild COVID disease. All were treated as a home observation. And it was probably Delta variant, those were one of the initial patients. And typical presentation was fever, cough, dyspnea, headache, loss of smell, and no one was vaccinated. And PASC patients were age and sex matched with 10 women who had post-traumatic tachycardia syndrome and 15 healthy controls. Patients were evaluated using Brigham protocol, which consists of standard or standardized autonomic function tests, which are combined with cerebrovascular and respiratory assessments and skin biopsies. We are using continuous transcranial Doppler for measurement of cerebral blood flow in the middle cerebral artery during the TIL test. Standard autonomic cardiovascular tests, which were described by Mitch a few minutes ago, measures cardiovagal parasympathetic system and sympathetic adrenergic system. We are using also pseudomotor tests for postganglionic measurement and skin biopsies for evaluation of small fibers. We're looking for both sensory and pseudomotor fibers. We also evaluate several inflammatory and autoimmune markers for assessment of low-grade inflammation. So results show that PASC is associated with multi-system involvement affecting cerebrovascular, including cerebrovascular dysregulation with persistent cerebral arterial vasoconstriction. There was also evidence of small fiber neuropathy and related widespread dysautonomia. Also, we find this respiratory dysregulation and evidence of chronic inflammation. A few words about small fiber neuropathy. We find this type of neuropathy in 89% of PASC patients and 60% of POTS patients. No one has small fiber neuropathy in controls. Most common type of neuropathy was mixed, affecting sensory and autonomic fibers simultaneously. Slide on the left side shows typical example of the healthy controls with number of the epidermal fibers marked on those red arrows. And the right side is a PASC subject with reduced number of the fibers, which is consistent with a small fiber neuropathy. Our finding was actually confirmed by our colleagues from MGH, by Dr. Oaklander and her team, that found also evidence of small fiber neuropathy in 65% of PASC patients. Also, these patients were treated with steroids and IVIG, and about half of the treated patients improved. So it was concluded that the results of this study support hypothesis that some of the long COVID symptoms are results of small fiber neuropathy, and also positive response to immunotherapy with IVIG on steroids strengthen the link between small fiber neuropathy and this immunity in PASC. This another report described painful paresthesia and numbness associated with small fiber neuropathy in PASC. This came from Mount Sinai Hospital. Most of patients improved on symptomatic therapy. Cerebrovascular dysregulation is one of the major findings of our study. Abnormal cerebral blood flow was detected in 100% of the PASC patients, so in everybody. Orthostatic cerebral blood flow velocity declined in average 20% in PASC patients, which is similar to the POTS patients. So this is a group statistic from the TILT test showing supine and orthostatic response in the cerebral blood flow. The orthostatic cerebral blood flow declined in both PASC and POTS in spite that no one had orthostatic hypotension, meaning that decline is due to cerebrovascular dysregulation. Again, the decline was about 20% in both the POTS and the PASC patients, which is clinically significant since that decline is associated with signs of cerebral hypoperfusion in POTS patients. And this slide shows summary of the TIL test showing orthostatic tachycardia in the POTS, reduced cerebral blood flow velocity in POTS and PASC, and this particular pattern of the respiratory dysregulation associated with hypocapnia, which I will mention in a few minutes. Dysautonomia was also frequent in PASC. In our group, objective evidence of dysautonomia was detected in everybody in both PASC and POTS patients when we combined abnormalities in different autonomic systems. For example, pseudomotor dysfunction was detected in 67 of PASC patients, parasympathetic in 40%, and sympathetic adrenergic in 100%, which is kind of similar in terms of the frequency than in the POTS. And no one had dysautonomia in controls. We just completed another retrospective study with expanded number of the patients, which is in the submission, that confirmed widespread dysautonomia in PASC. In this cohort, autonomic failure was slightly worse in POTS compared to PASC. Again, orthostatic hypotension was not present in anybody. Mayo Clinic also evaluated dysautonomia in PASC patients, and they find out pseudomotor dysfunction in 36, cardiovagal in 27, and cardiovascular adrenergic in 7%. So this is kind of similar than our finding. And interestingly, it's also very similar than we found. Most common was orthostatic symptoms. Most common complaint were orthostatic symptoms without evidence of tachycardia in 41%. It was concluded that dysautonomia was frequent but mild, but the most common finding as orthostatic intolerance was without any objective finding. We think these patients, they had decreased the cerebral blood flow as in our case. And this is another study of Blichstein and Whitelaw published as a retrospective chart study. And they look on the patients referred to Autonomic clinic for new onset of dysautonomia. They evaluated 20 patients, and the most common diagnosis was POTS in 75%. Although the diagnosis was not made by autonomic testing, but by standing test. The dysautonomia was quite disabling. 60% of patients were unable to work. But another study found POTS only in 2% out of the 85 patients. Probably a referral bias plays a role. Autonomic system controls all organs, as you heard before the lectures. Therefore, widespread dysautonomia, as found in the PASC patients, can affect multiple organs, causing a variety of complaints. We also find respiratory dysregulation, which was common as well. Supine and orthostatic hypocapnia was present in the PASC patients, while orthostatic hypocapnia only was in the POTS, which is typical finding for the POTS. So this is the end-tidal CO2. PASC patient that decreased the end-tidal CO2 even supine slightly, which persisted throughout the tilt, while in the POTS patient, normal supine end-tidal CO2, which declined during the upright position. Carbon dioxide has a profound effect on the cerebral blood flow. Hypocapnia is causing cerebral vasoconstriction and reduction of cerebral blood flow. Hypocapnia is cause of the reduced cerebral blood flow in POTS, since when you're adjusting the effect of the blood flow due to hypocapnia, it will correct the blood flow in the POTS patient, but not in the PASC. It implies that in PASC, the reduced blood flow is due to cerebral autoregulatory failure associated with stiffness of the cerebral arterioles. Inflammation was also checked in our cohort, and inflammatory dysregulation was also found in majority of the patients. Elevated inflammatory markers were found in 67% of the PASC and 70% of POTS patients, which is very similar. These findings are consistent with low-grade inflammation. In summary, PASC is associated with multiple system dysfunction. It can be argued that we have a low number of the patients, but all our findings were replicated by other studies. Cerebrovascular dysfunction results in cerebral orthostatic hypoperfusion due persistent cerebral arterial vasoconstriction, and it may cause orthostatic intolerance, fatigue, brain fog. Dysautonomia may contribute to orthostatic intolerance, fatigue, dyspnea, temperature dysregulations, GI and urinary problems. Small fiber neuropathy may cause pain and other sensory disturbances. Respiratory dysregulation may cause with hypocapnia may cause dyspnea, increased fatigue, alkalosis, and maybe tissue ischemia. And low-grade inflammation, probably affecting the small vessels, can be a pathological substrate of PASC. We think that virus somewhat triggers a dysregulation of autoimmune system with subsequent release of probably inflammatory cytokines that can lead to low-grade inflammation. Few words about the therapy. Therapy is mostly supportive, symptoms-oriented. There's a limited evidence about effectiveness of pharmacological approaches. There are multiple ongoing clinical trials using off-label medications or new medication. exploring the role of supplements, vitamins, probiotics, antioxidants, steroids, IVIG, and other immunomodulators. And they suggested pathophysiological mechanisms of PASC. This picture is taken from Dr. Umesh from Infection Journal. Based on his current knowledge, PASC mechanisms are very complex and interrelated, multiple mechanisms in parallel. And the main mechanisms can be divided by three major categories. Those are direct cellular tissue injury caused by cytotoxicity. Second, immune activation and inflammation, probably through antigen cross-reactivity or via injured cells damage. And third, defect of physiological response or maladaptive response with hormonal changes and abnormal intracellular signaling pathways. It is postulated that combination of these three mechanisms are responsible for the respective clinical symptoms. And these slides, there are several potential therapeutic neuroimmune targets. The list is not complete and only shows some examples. The therapy can focus on particular metabolite or protein, for example, on interleukin-6 blocking, or using antibody against certain antibodies. For example, recently described antibodies against several types of the GPCR receptors. Those antibodies found in the PASC patients, they might activate those receptors, causing, for example, autonomic dysregulation. They can, for example, activate adrenergic receptors. Or potential therapy can target more widespread or more generous pathways, for example, to modulate toll-like receptors or modulate B or C T cells, or modulate coagulation cascades. There are multiple clinical trials that hopefully will give us some answers soon. There was also an interesting study in Nature recently showing several genomic loci that are associated with either predisposition to COVID or to severity of the COVID disease. And there are a number of clinical trials, and as September 21, there were registered 201 clinical trials. About half of them were observational, and less than half interventional. And interestingly, most of the trials originated in academia. And this was my last slide. Thank you.
My name is Chung. I'm from Johns Hopkins. I'm a neuromuscular specialist by fellowship training, but did my residency in physical medicine and rehabilitation. So I have a privilege of working with other rehab therapists, which I think is very important for the treatment of this condition. So for this 20 minutes that's assigned to me, I'll focus on some treatment strategies for dysautonomia in PASC patients. Next slide, please. So before I talk about the treatment, I briefly touch on kind of a little bit of a framework for diagnosis, how I approach to this condition. So when I say PASC, it's at this point it's very loosely defined. It really includes everything that can arise and causing long-lasting symptoms after COVID infection. That includes pulmonary fibrosis or post-ICU syndrome, cardiomyocytes, and pulmonary embolism and everything. Obviously, I'll be focused on PASC and dysautonomia, which I believe a lot of people here believe to be one of the probably most significant and largest problem in PASC patients. That's also very debilitating. Next slide, please. And in the previous talks, Dr. Miglis, Professor Stiles, and Dr. Novak really beautifully pointed out that first, although at this point a lot of PASC symptoms are discussed as being some mysterious conditions, a lot of people in the field have actually recognized these symptoms pretty well. The clinical phenotypes are very typical for, in many cases, clinical diagnosis of PASC. That includes difficulty breathing, especially after some short activities or exercise, severe debilitating fatigue, brain fog, sleep problems, and lightheadedness and so on. So I'm not going to go over all the symptoms. This actually table I got it from CDC government that listed all the symptoms of PASC, and you recognize by now that these symptoms are very typical for again clinical diagnosis of POTS. Next slide, please. So what is POTS? So how do you explain all the kind of multisystemic symptoms? Again, just before I get to the treatment part, I see those symptoms as primarily vasomotor symptoms, meaning the blood flow kind of problem. Can you kind of move over slides, please? It's an animation. So if you can just keep going. So basically, they have a lot of post-exercise malaise and flares because basically their blood flow is not really getting to muscles when they exercise. They have a brain fog with this concentration, and Dr. Novak just beautifully illustrated in his slides that there's a severe reduction, just about 20% reduction in blood flow to cerebral blood flow whenever they're having brain fog. And also they have a chronic fatigue, orthostatic intolerance. Now, these symptoms by default, they check for brain, heart. I work with a very large post-COVID clinic collaboration at Johns Hopkins. And in the beginning of COVID pandemic, they've actually done pretty much all the tests for heart. Whenever they have a heart palpitation and so on, they actually check heart MRI, cardiac MRI for pretty much all the post-COVID patients. They get the MRI of the brain. We did everything, and rarely we find any primary heart infection or inflammation or brain, disease in the imaging studies or other things. So, it looks like it's each organs are probably likely normal. It's more vasomotor blood flow kind of problem that's affecting these multiple organs. But that's probably likely coming from autonomic nerve denervation that's regulating the blood flow. Can you go over the next slide, please? So I call this pump failure symptoms. And just can you please move over? Yeah. At the same time, maybe it's a compensatory mechanism, or maybe this abnormal barrel reflex function. Can you move? Yeah. There's also paradoxically increased sympathetic activation. And can you go on? And causing, go back to the slide, sorry about that. So causing all these central sympathetic symptoms that causes anxiety, palpitation, insomnia. They wake up in the middle of the night all the time. They have a slow GI motility that may predispose nausea, vomiting, or constipation down there, and hyperhidrosis. So next slide. Basically, when I approach therapeutically approaches POTS, I kind of see two different clusters of symptoms, which is one, vasomotor dysfunction, denervation symptoms. Basically, it's a blood flow pump failure symptoms, which explains fatigue, brain fog, exercise intolerance, migraine, and other things. On the other hand, there's a kind of more central sympathetic activation that causes anxiety, palpitation, insomnia, and GI problem, and so on. And I think this is very important kind of diagram because their symptoms are very diverse, but it comes down to vasomotor symptoms and sympathetic symptoms. And if you think about it, these are very paradoxical because you have those symptoms that's coming from too much excessive adrenaline or sympathetic activation, and also at the same time peripheral sympathetic denervation. So for example, there has a lot of therapeutic implication. For example, generally in POTS field, it's been well known that beta blockers are very important to reduce palpitation and calms them down and help with a lot of patients. But at the same time, especially with the higher dose, it can worsen some of the fatigue and orthostatic symptoms, and vice versa. So I think it's really important for clinicians to really understand this paradoxical nature. And in my experience, these symptoms can be very diverse and dynamic. So for example, for same patient, certain dose of beta blocker may work beautifully for maybe a few months. And then, afterwards, it may actually work the other way too. So I think it's essential to understand the paradoxical nature of these symptoms and also closely monitor their symptoms and make sure we are kind of very flexible in terms of using our medications. And for these reasons, I try to avoid polypharmacy, because if they are getting like 5 or 6 medications, there's no way to know what's helping, what's not. So keeping that in mind, well, first, next slide, please. I think from a neuromuscular standpoint, I think the localization, to me, with some indirect evidence, I think this is more like sympathetic ganglionitis. It's a post-infectious. Their symptom onset is very acute and probably attacks, inflames some different sympathetic ganglia, chain ganglia, and then causing both vasomotor symptoms and pseudomotor symptoms and other things too. Now, next slide, please. Then how do you approach this problem? I think, well, generally there are probably 2 approaches there, and I'm going to talk about potential anti-inflammatory immunomodulatory approach a little later on. But no, for symptomatically, they have these vasomotor symptoms and excessive sympathetic symptoms. How do you approach to that? So I try to approach it a little differently for the different kinds of problems. So for example, for vasomotor symptoms, pump failure symptoms, we try to do very aggressive volume expansion. Whereas for sympathetic overcompensation, we'll try to use some medication or some meditation techniques to bring down their kind of adrenalines and anxiety level. Next slide, please. So volume expansion for audience here, I don't have to really explain too much. We're trying to expand the volume and increase blood volume to help with the vasomotor symptoms. And the effect of volume expansion, well, the reason that I think those like for example insomnia and other things are connected to this whole PASC symptoms is that oftentimes if you do really aggressive volume expansion, other symptoms get better too. Not only their fatigue level gets better, brain fog gets better, oftentimes they sleep better and anxiety level goes down as well. I think a couple of things to keep in mind is that volume expansion is really easy in the concept, but actually to do is not that easy. They have to drink a lot of excessive amount of water and high level sodium as well. And oftentimes it takes a lot of time for patients to modify their lifestyle to achieve this. Oftentimes I do IV saline hydration and just acute volume expansion with IV saline bolus. And you'll see that a lot of these patients, immediately their symptoms, some of their symptoms improve. Well, the problem is that IV saline infusion is really not for long-term solution, each time, because even if you give 1 liter bolus or 2 liter bolus, it doesn't stay in your body for a long time. I try to do limit this IV hydration to bridge some physical therapy. I'm going to mention a little bit later, the next slide, about the exercise intolerance. But sometimes whenever they try to do physical exercise, if they cannot tolerate it, I just try to bridge them with the IV solution, for a short period of time, for a few weeks or for a few months. Of course, on top of oral hydration and salt intake, we use various medications such as midodrine or fludrocortisone to optimize volume expansion. I try not to use those medications until I make sure that they're really actually modifying their lifestyle and diets and drink a lot of water, because without it, usually doesn't help a lot. Now, I see physical exercise as a part of volume expansion treatment. And my rationale for physical exercise, why it works, I think it's for long-term cardiovascular training, it increases our blood volume. It's possibly because they increase their hematocrit, they make more red blood cells, or in part because of skeletal muscle pump that's returning more blood back to the heart and lung. So either way, it works really well. As I said, we have a multidisciplinary clinic. I work closely with our physical therapists, and over long term, once they can achieve physical exercise certain level, they actually feel much better. They actually feel better with their fatigue and brain fog and other things. Now, next slide. However, there are a couple of issues that we really need to address. First of all, it's a gradual cardiovascular training. It takes a long time, I think, for both clinicians and patients, they really have to understand it takes a long time, oftentimes more than several months to a year. So the key is really not to give up in the middle. It's not something that they feel just better after a few weeks of exercise. And also, they have a lot of limitation in exercise in the beginning. So next slide, please. So this is kind of just move all the animation, please. So this is kind of theoretical graph for exercise in PASC patient. Now, the black line is whenever the normal people do the exercise. Now, the x-axis is time, the y-axis is heart rate. Go back to the previous slide, please. Yeah, so normal people, when you start exercising, your heart rate goes up, and then when you stop the training, it goes down, cools down right away like that. PASC patient is kind of red graph. It's kind of theoretical graph that we see all the time. In the beginning, they kind of increase nicely as they match to increasing metabolic requirements from their skeletal muscle, I guess. But at some point, they shoot up and they cannot tolerate at some point. And this, well, I just call this point of no return. And that point can be only 5 or 3 minutes into a stationary bike. And these patients can be very young, 20 and 30s kind of patients. And the thing is that before that point, people really have a hard time tolerating the exercise. And the idea of this gradual training program is to really push this point further to the right side over time. Next slide, please. So we use another medications to bring down sympathetic symptoms. Again, for the reason that I mentioned, I try to do more non-pharmacological stuff with, such as meditation and mindfulness. They can be very effective. Next slide, please. And also, again, with education, for a lot of different things, is very important, like avoiding dehydration. Certain things like caffeine can actually dehydrate people. Avoiding infection can avoid flares. So they need a lot of education piece to change it. A lot of people have MCAS, mass activation syndrome. And because of that, they need to go over certain different dietary kind of regimen to avoid possible triggers. Next slide. And a lot of people have kind of hard time ambulating because of orthostatic intolerance. We use certain devices for them to be able to get around better. For PASC patients, something like rollator can be helpful with the sitting function, because sometimes they can faint or they can sit down. Next slide. Of course, we use physical measures such as compression stocking and binders. We make sure that it's thigh high, and abdominal binders are very important. Next slide. So it says animation, so please go through that. So basically the basic immune therapy is that it's post-infectious. So I think the idea is that whenever we make whatever the antibody we make to fight against COVID-19, maybe one of them or few of them is autoreactive, and it kind of recognize our autonomic ganglia potentially. We don't know exactly what the target organ is at this point, but potentially the autoreactive antibodies inflaming our own body and causing post-COVID PASC, causing sympathetic vasomotor fibers. So next slide, please. So the idea, and it's possible that the target can be, can you move this animation as well? It can be kind of interfering at the synapse, or it can be axonal, it can be neuronal attack at the sympathetic fibers. Next slide, please. So can you keep moving? Yep. So the idea for the immune therapy is to bring down potentially autoreactive autoantibodies. There are actually few available for the treatment, immune modulating treatment, that includes a high dose IVIG. We know that this kind of brings down all the IgGs in the body. So, it kind of probably precipitates, neutralize some autoreactive IgGs. SCRN receptor antagonist is a newer kinds of medication. We'll be doing clinical trials on post-COVID PASC patient with using this medication. That basically, this medication also brings down all the IgGs in the body. So it's a bit, we don't have to know which target, which target organs are for these autoreactive antibodies, it just brings down all the IgGs in the body. So we're hoping that the immune-mediated PASC from post-COVID, I think, is going to work. Now, I know some people have used rituximab or high-dose steroids before. I'm a little bit kind of hesitant to use rituximab on these kind of patients for many reasons, but I know somebody asked questions about potential HDS, TSHDS, FGFR3 antibodies. Those are IgM-mediated autoantibodies. So we don't know if autoantibody for PASC are IgG-mediated or IgM-mediated. So potentially there's a role for things like rituximab. But although these are, to me, it's a little too strong immunosuppression. And based on potential risk and benefit, I'm still not 100% convinced about using this. But we'll need some more research to find out what the autoreactive antibodies are at this point. Next slide, please. Okay, well, I'm gonna skip this mass activation syndrome for the interest of time. And this is actually my last slide. Thank you very much for your attention.
So I think, I believe I'm up next. Welcome to you all. My name is Satish Raj and I have no slides. Basically, I think I've been asked to give sort of a couple of minute overview of some of the stuff we've heard and seen and try and put this into context. And what I'm hoping to do is actually leave a little more time than perhaps we had planned for some of the questions that have been entered into the Q&A. I think one of the key messages from all of our speakers that should come through is that this is complicated. And it's complicated for different reasons. There are lots of things you could argue are complicated, but I think one of the challenges, and there are many challenges, right? I mean, and these challenges are all things that we've seen in the POTS world and in the autonomic dysfunction world before COVID, and it's not been made easier. One is, at least until recently, there was no real administrative data to determine how common these diagnoses are, assuming that people can make the diagnosis, the physicians can make the diagnosis. I think that's changed for the PASC or long COVID. It actually is still true for POTS, although that will change at some point. So it's tough to get a handle on how much there is. The other challenge when discussing the different pathophysiological mechanisms is that not everyone has all of these, right? These are things that have been seen in some patients with POTS in the older literature and in the long COVID cohorts. And that's important to understand that, I think, certainly my source of medical knowledge, Twitter, often people seem to sort of look at one treatment and assume it's a treatment for all. And if one person got better with a treatment, that's great, right? Because this actually can be debilitating, out of all proportions to individuals. But it's important not to jump from that anecdote of one and say, well, everyone should be on X or Y or Z, because the truth is we don't understand what's causing it in the different subgroups of people. I think in the POTS world, I suspect that, my colleagues on the session would agree that there is not a thing that causes POTS. There are different things that end up with a similar phenotype. And I think PASC or long COVID is that, but even more so, because the presentations are even more varied than we see in POTS overall. So I think, while, we all want answers, I think we really need to take these initial steps, quite frankly, what are really small studies so far, because this is all still relatively new to us. And we need to actually start trying to figure out who those subgroups are and then do studies of therapies. And I applaud, several of the talks today, my co-presenters have highlighted some of the studies or areas for study that are coming up. And I would want to emphasize that is needed. It's not adequate to say, hey, 3 people said this is the problem, and so everyone should go on therapy X or therapy Y. I think we've learned in the POTS world, it's not that simple. And certainly, we have to sort of step back and not give up. I think, this has brought a lot of it. Long COVID, the presentation overlapping with POTS has brought a lot of attention to this, much needed attention. And that could be used to help springboard us to hopefully what's a better future as we start to understand it, because I think a lot of the solutions are going to be common. In the beginning, it's going to be using treatments that we've used traditionally for POTS and other related autonomic disorders in long COVID patients that look like that. But over time, we may actually be able to use the attention brought to it by the long COVID patients to help the larger group of patients that have suffered with POTS and other, related disorders for decades. And that's, maybe the good that can come of all this otherwise not so good stuff. With that, actually, I'd like to sort of, poke my panelists a little bit to press further on some of the stuff they brought up. And I was particularly intrigued by one of the slides that Dr. Novak showed. And in fairness, Safwan from Stanford was also intrigued. And so I will ask on his behalf. You indicated that the end-tidal CO2 in POTS patients and the PASC patients are low on standing, but when not standing, when supine, the PASC patients had a low end-tidal CO2 while the POTS patients did not. Any thoughts on what this means in terms of underlying pathophysiology, and if that's the explanation for the cerebral blood flow velocity changes that you also showed?
Well, we don't know exact mechanism, but respiratory dysregulation is very common in the past. It actually, this was one of the most common complaint in the UK study in post-COVID patients. So for some reason, the virus has propensity to affect the pulmonary respiratory system. In our patients, most of them, did have like very thorough pulmonary evaluation, so normal CT scan, so there was no any evidence of any organ damage. So it is probably something to do with the regulation. We don't know. It could be, for example, metabolic derangement. It could be damage of the small fibers, which are sensors in the lungs. So the brain is being full that has not enough, not oxygen, but brain is reacting to CO2 level. So it might be overcompensation. But short answer is we don't know, but it's very common. Dyspnea is extremely common in past patients.
Satish, I'll just, I can add into that. There is literature in the MECFS world already describing that baseline supine hypocapnia in patients with chronic fatigue syndrome. So there's some precedent for that.
Any thoughts on why?
I think metabolic derangement and inflammation, some theories there. But yeah, like Dr. Novak mentioned, no one's really elucidated those mechanisms.
Well, in orthostatic hypocapnia is long known for years. And there are two probably likely explanations. Julian Stewart described thoracic hypovolemia. So it is something to do with thorax or chest perfusion. And second theory is because in general, POTS patients tend to be hypovolemic. So it might be different perfusion, upper and lower portion of the lungs. So there is selective mismatch in sensing the CO2 levels, which might drive the brain to be hypocapnic.
Great. And before I hand the reins back to Dr. McPheeters, I did want to address one other question that I saw, and it had to do with anxiety and long COVID. And the question related to the presence of symptoms of sympathetic nervous system activation and whether that could lead to anxiety in the setting of at times very high heart rates. And this touches on, I think, something that Professor Stiles sort of alluded to, and that is that there's no reason why a long COVID patient or a POTS patient can't have an anxiety disorder. The reality is that a good percentage of the North American population does, right? But we haven't found that it's higher. And there very much is an issue where the somatic symptoms of anxiety are tachycardia and palpitation and lightheadedness and the things that are actually part of the hemodynamic presentation that we see. And certainly, it's not to say that all anxiety in POTS patients can be controlled by heart rate control, but if someone's heart rate's very fast and that's actually either associated temporally with the anxiety every time, or worse, that's the reason someone diagnosed anxiety, Before pulling out the Prozac, it may be worth trying to lower the heart rate a little bit and see. I've cured a lot of anxiety with beta blockers. They are wonder drugs when used appropriately, as Dr. Chung pointed out.
Yeah, can I add to that, Dr. Raj? I just want to say, I think that it's normal for patients who have new symptoms that are poorly understood and they can't find a doctor to help them. It's really normal for that to be a scary experience and for patients to express a fear of their symptoms. But I don't think you should interpret that as this is all caused by an anxiety disorder. I can tell you, I was terrified of my symptoms because nobody was telling me why it was happening or how to get rid of it for about 2 years. Hopefully, long COVID patients are going to get diagnosed faster with the increasing awareness, but taking the time to explain to your patient why they might be having tachycardia and palpitations and assuring them that it's not fatal might really help a lot in their quality of life and not sort of worrying about their symptoms. Patient education is a big part of managing dysautonomia.
Dr. McPheeters, over to you.
Thank you, Dr. Rush. What fantastic presentations. We have so many questions, so we're not going to be able to get through all of them, but we'll get through a few of them. And as I said before, we'll get answers to questions posted on our website as soon as we can. I wanted to, well, Dr. Rush took the question that I was going to ask first, but I wanted to bring us back to one other question related to the research. And Dr. Miglis and Professor Stiles, I think you both sort of touched on some of these issues and some of your responses to questions that came in through the Q&A, but how hard it is to study all of these conditions, given the lack of data that's existing in EHRs, for example, in our administrative data systems, and what we need to do better in terms of how we study dysautonomia and all these related conditions. So I'm going to pitch it to the two of you and ask you to come up with the one thing that you think we really need to do better now to get a handle on what is clearly very complex and common. Professor Stiles, I'll start with you because you came right off mute.
Sure. So I think that the simplest thing, I recognize that not every Recover site and not every long COVID clinic has substantial autonomic expertise. And it's not their fault. Most doctors aren't trained on this. I think the simplest thing we can do is have all of the sites doing 10-minute orthostatic vitals the right way, because you could definitely mess that up, doing it the right way and screening all of their past patients for this, not only for research purposes, but to also make sure that we are accurately diagnosing these patients, which affects the EHR research down the road, right? And to make sure that they're going to get proper intervention and treatment if they are suffering from it. Well, we don't know the whole mystery of long COVID. We do know effective treatments for orthostatic disorders. Mitch, I'm sure. I mean, there's a lot more I could say, but I don't want to give the whole call.
Yeah, no, I agree completely. I think we're advocating at a minimum for at least 5 and preferably 10-minute orthostatic stand tests for all Recover patients and Compass 31. These are very low-cost tools that'll really help us understand the true prevalence of these conditions.
Yeah, we've also advocated for, in a sub-cohort, doing a full autonomic testing at like the autonomic labs that these doctors run. Not every site's going to have that, but that's the more detailed testing that really is necessary, like beat-to-beat blood pressure monitoring and stuff. You're not going to get that from bedside orthostatic vitals. So I hope that can be done in a sub-cohort of the overall study population.
Thank you. This is very complex.
I like to add that that's the big problem because, again, surveys, they are validated, but they are still non-specific and they are not really designed to replace diagnosis. So still the best is to do establish autonomic testing to get a detailed profile of dysautonomia. And also if judgment of the effect of any intervention, it is usually not a yes to no answer. So if you want to detect some mild progression or regression, then autonomic testing cannot replace it.
take us in a slightly different direction now with a couple of questions that have come up multiple times in our Q&A. So clearly they're on people's minds. And one of them is for patients with existing diagnoses pre-COVID of various dysautonomic conditions. Are we seeing anything about what COVID does in those patients in terms of post-COVID, whether symptoms worsen or improve? What direction are we seeing anything in the literature right now or in the research? I'll point that to Dr. Novak.
There are a couple of, I think, anecdotal studies that show worsening of underlying small fiber neuropathies. We actually published one case study, worsening of the POTS, worsening of the autonomic failure in general. We did not publish, but we have probably like 10, 11 patients. For other reasons, we have pre and post-COVID autonomic tests. And most of them had autonomic neuropathies or small fiber neuropathies with dysautonomia, and most of them actually got worse. So most commonly, it can cause worsening of the underlying autonomic problems.
I just want to add to that in the survey-based study that Dr. Miglis and I did, we saw an overrepresentation of people who had pre-existing dysautonomias, and we did not recruit through the dysautonomia international support groups. We were going to long COVID groups. So I think that it's not surprising because we've known prior to COVID that when people with dysautonomias get a viral infection or other kind of immune stimuli, a subset of them will kind of worsen. And I guess it remains to be seen, like, how long does that flare last? Is it permanent? Is it for 3 to 6 months? You know, I think that needs more research. We actually don't have good longitudinal research in POTS and other conditions to know that, but hopefully some of that comes out of Recover, at least in tracking long COVID POTS patients over time.
Sure. Dr. Raj, you came off mute. I think you have something to say.
Well, I was going to say, I don't have any patients who've come to me to tell me that COVID has done wonders for their POTS symptoms, right? I mean, I have zero. We have some the other way and some that sort of, recovered back to baseline. So, if the question was, is there, a therapeutic hope that COVID will be helpful? I think the answer is no. I think we deal with the fallout.
Mm-hmm. Absolutely. Another question that came up multiple times in the Q&A was whether or not there was any sort of hormonal influence on these various conditions. And I just saw you nod, Professor Stiles, and so I think you might have something to say. Or Dr. Novak, Dr. Chung, do you have any thoughts about that?
Can you say again, please, your question? I don't understand.
The question was asked several times in the Q&A as to whether or not there was a hormonal influence on symptoms, either on symptoms, but then also a question was asked as to whether or not hormones could be considered in treatment as well.
Well, I have very limited experience with it. Maybe someone else can answer. I have only a few patients. They did have accompanying adrenal insufficiency, for example. So they also had concomitant hormonal treatment or replacement, but I'm not sure it is how common it is.
Yeah,
So
in the beginning, I used to send all the POTS patients with fatigue to our endocrinology colleagues and with the potential adrenal. Sometimes some people say adrenal fatigue, and our colleagues all think this is not really scientific term. And, they believe it's not really primarily an endocrinological problem. Professor Stiles and Raj may have more.
I was actually going to say Satish is the only one on this call who's actually done a sort of, gynecological related study in POTS. But just, I almost think that's a question that is so obvious. It's so funny that we actually don't have good hormone research. POTS pre-COVID was 90% female. Of course, there's a role of sex hormones, but no one's bothered to study it so far. And in long COVID, I think it's also female predominant. And I don't think this is surprising because most patients are probably going to have some post-viral autoimmune immune mechanism. And the vast majority of people who have autoimmune diseases are also women. So there is a role for sex hormones and sort of tolerance to self, and anecdotally, we have a couple of case reports on adolescent POTS patients who were transgendered, who transitioned from female to male using sex hormone, testosterone, and their POTS symptoms improved. So I'm not telling women with POTS to go out and get on testosterone because, there's all kinds of reasons you might not want to do that, but there absolutely needs to be more research on sex hormones and on whether that can lead to treatment options as well. But I think Dr. Raj has, he has actual studies he's done on this.
So the two things I'd say is that, hormones obviously can mean lots of things, but in terms of sort of cyclical variability in young women, we did a study that was actually very simple a long time ago at Vanderbilt, where we got patients with POTS and actually healthy volunteers. And those that know our Vanderbilt study means, Vanderbilt grad students largely. But basically, we got people to rate relative lightheadedness at 4 different phases of their menstrual cycle. And the interesting thing was the pattern was identical, right? So around menstruation, and second worst was just before, women were more lightheaded than at other phases of their cycle. And this was amplified in the POTS patients, right, who had more lightheadedness as part of their disorder. But if you just shifted the pattern down, the cyclical pattern was the same, right? So whatever's going on, there's something in the background, and then other things contributing to lightheadedness. It may amp it up or down. And so it's not uncommon for POTS patients that we have to sometimes go on longer-term birth controls where they, keep their hormonal levels sort of higher and have breakthrough bleeds, say, every 3 or 4 months instead of every month. Not because it makes everything better, but it decreases the number of worse times, if you will, right? So it's a management strategy. Separate from that, hormones could refer to blood volume regulating hormones, and we've certainly done some work that the majority of POTS patients, when we were looking at this aggressively at Vanderbilt, I'd say 70+% actually had a low blood volume when you objectively measure it. And in one of our early studies, we found that the renin, angiotensin, aldosterone system seemed to act a little funny in some of those folks. And again, that's not everyone. That's, in the cohort that we saw where aldosterone responses were blunted. And interestingly, this ties back to exercise, where one of the things that exercise does, and I forget who, but one of the speakers alluded to this, is that it actually, both acutely and then chronically, there's a slightly separate effect. It actually increases the responsiveness of aldosterone release to renin activity, right? So you actually, one of the things exercise does is it actually increases your blood volume, aside from other exercisey things, right? So it does actually alter your hormonal pattern in terms of blood volume regulation. So there are lots of different things. The challenge with all of these are, how to make them actionable, right? So even in the patients with blunted aldosterone, it's very sensitive to things like sodium intake and volume status. And so most of these patients weren't out of the normal range, right? But when you look at a group compared to sort of a similar group that's matched, there may be something there.
Dr. Chung, did you have anything you wanted to add to that?
Oh, no, not for now. So.
Okay, great. And I'm getting the message that we need to wrap up really quickly, which is terrible because what an amazing set of presentations this was, and what an incredible conversation. So we do have just a couple of minutes. So I'm going to just put our speakers on the spot and ask them to share with us the one thing in one sentence that they'd like folks to take away from this. And it might be something that you answered in the Q&A that you feel like other people might want to hear because there was so much going on. Dr. Novak, we'll start with you.
Well, from my perspective, we are extremely eager to go to the root cause of the PASC. It is probably the most studied virus ever. And as I show, there are multiple potential targets. So we are hoping we will get some answers. And we are looking forward not only because of that, but also we can extrapolate principles of the treatment and mechanisms, also some other conditions like POTS in general or post-viral syndromes, chronic fatigue syndromes.
Okay, thank you. Dr. Miglis, running down the clock.
So autonomic dysfunction is common in PASC, we know that, and it may not be related to the severity of the infection, which is another important point.
So, Professor Stiles.
We need clinicians and researchers to really take the initiative to learn how to screen for and treat autonomic dysfunction in long COVID and in all the pre-existing patients who are out there who are not getting good care.
And Dr. Chung.
Yeah, my last comment is an answer to your first question about what's the most single important thing about the research, I think is biomarker study, the discovering biomarker, which I think is very kind of relatively low-hanging fruit at this point because it's actionable if you find autoantibodies. it's actionable, we can use immune drugs. So that's what I would like to emphasize for research.
Great. Dr. Raj, one sentence.
Two.
Okay.
So I think, the goal of finding the underlying cause and the holy water to fix it is laudable. I'm getting old, and I like to think I wasn't so cynical in my youth, but the truth is that I think it's a mistake to avoid treating the symptoms, at least in the short term. It does, while Dr. Novak and Dr. Chung find the cure, I think the danger is that a lot of physicians say, well, this is too complicated, I don't know about this, and they won't treat what can be treated. And a lot of the symptoms will respond to treatments within their expertise and their specialty that are organ-based. And I think the patients need that now while these other things go on for the big picture.
Great, thank you. Yes, so we just want to thank everyone for joining us today. We really appreciate you registering, sending in questions, engaging in the Q&A. We will be getting this ready to post on our web just as fast as we can. recovercovid.org is that website. Also on that website is information on upcoming webinars. These are the topics that are currently laid out. More to come as this program grows. So really, we do hope that you join us and continue to check back for more information as more is learned. Thanks again to our amazing speakers. You are absolutely outstanding today. Thank you. We will see you all at the next one.